Colleagues. And by the way, this meeting is being recorded. Welcome to all of you and to our very dear colleagues from the Ontario Medical Association. Before we begin, I'd like to just start with a reflection about the territorial lands upon which NOSM's entire campus is located on the homelands of First Nations and Métis people. Here in Sudbury, we're located on the territory of the Anishinaabe Nation, specifically the Atikameksheng and Wahnapitae First Nations. And in Thunder Bay, the buildings are located on the Fort William First Nation. And as we reflect on this, and as you hear about the priorities today of the Ontario Medical Association and the relationship that NOSM has across all of Northern Ontario, think about the critical issues that we are facing and the reflection not just about land, but about reconciliation, about truth and reconciliation, about the legacy of residential schools, about the climate and Mother Earth, about the impact on health and social determinants of health. Before we begin, I'd like to thank the colleagues, Dr. Adam Kassan, Mr. Alan Odette, the Ontario Medical Association, for coming here today, even though we are separated for public health reasons in separate rooms, but really very much to say thank you for recognizing the challenges and inequities that we face in Northern Ontario. NOSM was actually established in 2005 in response to doctor shortages in Northern Ontario. And since that time, this small little mighty medical school is about to be proclaimed to become Canada's first freestanding medical university, has graduated almost 800 physicians and almost 700 residents. And we have provided people close to 250,000 people, we estimate, with a family doctor since we've been in place. We have actually had a major economic impact on the region. Nevertheless, despite that, we are facing an epidemic, a series of epidemics within the pandemic, an epidemic of the opioid crisis, an epidemic of physician burnout and healthcare professional shortages, and the epidemic of difficulties with healthcare delivery to remote and rural communities, especially First Nations communities. So despite our progress, we find ourselves in a state of crisis. And as our colleague, Dr. Newbury, will point out, there is an ongoing challenge with health human resources in Northern Ontario. So thank you, Dr. Kassam. Thank you, Mr. Odette. Thank you to the Ontario Medical Association. We've already begun having critical conversations about making systemic change and making transformation in the system to have that level of commitment and that level of disruption that we need to make an impact in Northern Ontario. In Northern Ontario, at the Northern Ontario School of Medicine University, we will aspire and we will make possible the impossible. Because today, with this collaboration, health starts here. The health of Northern Ontario is going to become significantly changed as a result of the decisions we're going to make with this partnership. We're a small but mighty school, and we have over 90 communities involved in our evolving university. Health human resources is a leading priority in our strategic plan. And in fact, becoming a crucible for important conversations such as this is what we have promised in that plan. So thank you for being here in person. Thank you for being here online. And thank you for asking some of the important questions. Let's make this a dialogue. Let's make this important. Health starts here. Let's make the impossible possible. So I'd like to introduce the three speakers we're going to have today. Alan Odette, who, although I've heard so much about Mr. Odette, I met him for the first time in person last night, and everything they say about him is true. He is a business leader with expertise in organizational transformation, and he gets the connection between healthcare and the economy and healthcare and community. He's been on numerous private and not-for-profit boards and committees, and at present, he's the vice chair of the Mark and Stovall Hospital Board of Directors. Alan is actually leading the OMA into a significant transformation from being the old way to becoming a mover and a shaker and leading change. The current president of the OMA, Dr. Adam Kassam, is an absolute delight and pleasure to get to know. And again, it was lovely to have a chance to see you last night. We know Adam actually does come to the North occasionally, and he's committed as a physiatrist and a clinical associate, currently working at Runnymede Healthcare Centre and Athletes Care in Toronto. And his practice focuses on a very important area in musculoskeletal and neurological rehabilitation. He's a faculty lecturer at the Department of Medicine at the University of Toronto. And the third speaker will be Dr. Sarah Newbury, who of course is our own Assistant Dean of Physician Workforce Strategy here, the inaugural Assistant Dean at the NOSM University, and she is located in Marathon, Ontario. She works with our faculty, communities, and partner organizations to strengthen physician workforce in Northern Ontario. And I'll tell you one thing about Sarah, she is making a big impact. She's showing us the way on how to get the real data and how to address the real issues when it comes to the needs of Northern Ontario healthcare professionals, especially with an emphasis on physicians. As a rural generalist for over 20, almost 25 years, Sarah has held many leadership roles in primary care, and I'm so pleased that she's working on our team. There will be opportunities for the media to ask questions in the chat, and I see there are almost 10 questions already. What we will do is we'll go through these questions at the end of the presentations. And then, of course, we have a chance to go through other questions live. These will be moderated by Ashley Molnar. However, I will also be able to moderate your questions. So I'm going to turn this over in the first instance to Mr. Odette, Mr. Alan Odette, the CEO of the Ontario Medical Association. Over to you, Alan.
Dr. Verma, thank you for your remarks and your introduction. And hello, Dr. Newbury. We've seen all the work you're doing up here, but we've never been able to meet in person. So welcome this morning. And Dr. Kassam and I are thrilled to be in Sudbury today for some reasons we'll describe as we go through our presentations this morning. But I'm on the territory of the Anishinaabeg Nation, the Wantapate and the Atikametching, and I'm grateful to recognize that and be here this morning. 19 months into the pandemic, I think we've all seen just how fragile the healthcare system is in Ontario, and it's highlighted in Northern Ontario and other rural communities. Even before the pandemic, this was a significant problem. There's more than 1 million Ontarians that do not have a family doctor, including 1 in 8 in Northern Ontario. And without a family doctor, you can't really get preventative care to keep you healthy and access the rest of the system. Doctors, nurses, other frontline healthcare providers they're burning out. Everyone is fatigued. The level of fatigue, stress, and burnout in this community is overwhelming. And that's why Ontario is launching the largest consultation that it has in its 140-year history. We've been to communities right across this province doing this work. In fact, the first one we held was in Northern Ontario. And on reflection there, it was Dr. Kassam that said, you know, we need to come back to Northern Ontario and launch some specific and unique recommendations. And so that's the purpose for us being here today. We're going to be launching at Queen's Park tomorrow in Toronto. But we wanted to take a moment and reflect on what we heard when we were in Northern Ontario earlier in the year. We've consulted with more than 8,000 Ontarians, hundreds of doctors right across this province, and 120 plus other allied health professionals from long-term care, home care, nursing groups, and a whole host of many others. And so it really is the consensus of priority among those groups that have helped us create this prescription for Ontario, a 5-point plan. But of that, there is some very unique and heightened issues here in Northern Ontario. And that's why we wanted to come here today, to highlight it, to let our colleagues here know that Northern and rural communities matter to all physicians across this province, and that is really the purpose. The overall strategy of our platform is to reduce wait times and backlog of services, expand mental health addiction programs in the community, improve and expand home and other community care programs, fundamentally strengthen public health and our crisis pandemic preparedness, and overall really look to strengthen the team of providers that look after Ontarians. So I really want to just say thanks to Dr. Verma and your colleagues and others who've greeted us here in Sudbury last evening. I was particularly touched and impacted when we visited Crossroads for Change. This is a corner dedicated to remembering people who have died of opiate overdose here in Sudbury. There were over 2,000 crosses, 200, I apologize, crosses laid at the corner of an intersection here in Sudbury. We had an occasion to meet the mother of one of those boys, and I was very, very deeply touched. The people that are remembered by those crosses on that corner are somebody's daughter, son, mother, some cases husbands and wives. If we can't, as a community, get in front of this opioid crisis now with some urgency, I don't know when. So with that, I'm going to again thank Dr. Verma and invite our president, Dr. Adam Kassam, to step in. Dr. Kassam.
Thanks, Alan, and also thank you to Dr. Verma, Dr. Newberry. It's great to be here up in Sudbury. Let me start by saying that I'm so excited to be up here in the north. And as Dr. Verma was describing, I am a physiatrist, and I'm actually coming to Sudbury every 3 months to treat patients with spasticity in a number of long-term care facilities in Sudbury and the surrounding regions like Falconbridge, for example. And you know, Northern Ontario, when you get to know it a little bit, we recognize that it's vast and it's rugged. It has a natural beauty and a warmth of people and a sense of community that you can't truly imagine or really appreciate it unless you experience it here in person. And that generosity of spirit is alive and well, and something that Alan and our team have felt throughout our trip since last night. And we want to convey our thanks to the whole hospitality group here. It's been an unbelievable experience so far. But the North can also be a challenging place to live. Northern Ontario has 80 to 90% of the province's landmass, but only 6% of the population. And access to medical care and healthcare services for many people is impacted by weather and transportation infrastructure and frankly, just sheer distance. Just over 89% of people in the Northeast and just under 84% in the Northwest have a family doctor, or a nurse practitioner, or another regular healthcare provider. Now that is well below the national and the Ontario average. The Northeast has the second highest proportion of people over 65 in the province and the second highest number of those over 75. And life expectancy in the North is 2.5 to 2.9 years lower than the Ontario average. So providing equitable access to healthcare in Northern Ontario is a unique challenge requiring unique solutions. And as Alan said, that's why we're here today. Ontario's doctors are frustrated because patients aren't able to get the care that they need when they need it. And let's be honest, that's gone on for far too long. And healthcare in Northern Ontario can be improved, frankly, must be improved. The lack of family doctors in many parts of the North, and Alan described 1 in 8 here in the North, and 1 million people across the province don't have access to a family doctor. This is a real risk to the long-term health of residents. Here are some examples. Manitowoc had no practicing physicians for a period of time at the end of the summer. Nipigon had only 3 of the 5 doctors it needs. Sioux Lookout, which serves many remote Indigenous communities, had half the doctors it needs. And Wawa should have 6 doctors, but there are only 4 there now. The North is also short on specialists like psychiatrists and pediatricians and anesthesia. And that's why the OMA is putting forward 12 recommendations to fix shortages of doctors and other healthcare providers. In our plan, this prescription for Northern Ontario recommends that patients should have equitable access to care in their own communities. The incentives and supports for doctors and other healthcare professionals to practice in Northern Ontario should be reviewed and improved. We need a greater focus on education, training, innovation, and opportunities for collaborative care in remote communities. And med students and residents need the skills and opportunities to be confident in choosing rural and remote practices. The North was disproportionately affected by mental health and addiction challenges before the pandemic, and the situation has become ever more critical. And Alan was talking about the Crosses for Change, and yesterday we had an opportunity to meet with Denise, and she was able to share with us her story of her son, Miles. And it was a heartbreaking moment, but also a moment of reflection and the importance of work that we all need to do to move forward and improve. And Ontario's doctors, therefore, are calling for more resources to combat the profound impact of the opioid crisis and mental health issues in Northern Ontario. We especially need more social workers, mental health and addictions care providers, and resources for children's mental health. And all healthcare planning must be done through an equity lens and in a culturally sensitive way that breaks down those barriers. And we've witnessed during the pandemic that virtual care can improve access to medical care, but it requires a robust internet infrastructure. That's why the OMA is calling for the government to partner with internet service providers so that Ontarians who can't afford internet services, for example, those living in public or supportive housing, relying on Ontario Works or ODSP, and services and seniors receiving the guaranteed income supplement can get internet services at a greatly reduced rate. Ontario's doctors also believe that investing in the social determinants of health should be considered as important as investing in the healthcare system itself. That's why we're calling for a collaborative partnership with Indigenous Services Canada and Health Canada to address issues of safe drinking water and adequacy of healthcare facilities and resources in Indigenous communities. And we must also address the education gaps in Indigenous communities and non-Indigenous communities, as we know health is directly affected by education. Now, that's a lot of work that needs to be done. But these are important issues, and we at the OMA are committed to pursuing them. It's why we're here in the North. It's why we're launching this today. It's why we're here in Sudbury, and we're excited to continue to amplify that message moving forward. And we're excited to be delivering our platform tomorrow in Queen's Park. And with that, I'll turn it over back to Dr. Verma. Thank you.
Thank you, Dr. Kassam. And if we were not in a pandemic in an auditorium, there would be resounding applause for which is an unprecedented commitment to Northern Ontario needs. As I said yesterday, these issues are not dissimilar to what they are in the rest of the province. But the reality is they're much more magnified and much more critical. As you've said in your paper, the health inequity bathtub was 9/10 full before we hit the pandemic. And since then, it's now overflowing. The COVID pandemic has accelerated the potential retirements of healthcare professionals and burnt them out. But, if you can make it here, you can make it anywhere. And the issues here are that all of the ones you described can be also successfully implemented through the collaboration. And I absolutely loved what you said about working with both federal and provincial governments to make sure that accessibility is achieved, that the connectivity we need to have virtual medicine is achieved, and that the main issues of mental health and addictions and the people who are poor, the people who are homeless, the people whose health is so severely affected. But more importantly, as Mr. Odette has pointed out many times, the community in Northern Ontario, through mining in particular and forestry, is an economic driver for this province. And if it isn't doing well, the province isn't doing well. So I'd really like to bring this back home to what does this really mean? How does this affect the regular practitioner, the person who is on the front lines, at the coalface of all of these issues? We have Dr. Newberry here, as I said, has practiced for close to 25 years in Marathon, Ontario. And I'd like her to share with you all some of the stories, but also some of the important data about what's happening in Northern Ontario. Over to you, Dr. Newberry.
Thank you so much, Dr. Verma, for that welcome and introduction. It's really my privilege and my pleasure to be joining you today from the community of Marathon, where I have lived and worked for the past 25 years as a rural generalist family physician. It is in the traditional territory of Ojibwe people and the Anishinaabe, and specifically in the traditional territory of Big Tugong First Nation in the Robinson Superior Treaty. And again, it is a privilege to live and to work here. I love my work as a rural generalist, and like many, many of my rural generalist family physician colleagues across Northern Ontario, our work is broad. Many people may not realize the breadth of work that we do in our rural communities, but my work and that of all of my colleagues in rural communities involves work in primary care in our community-based offices. We cover the emerge department in the hospital. We do inpatient care, palliative care, home and community visits. Many of my colleagues also do obstetrical care, and some provide GP anesthesia and other services in our communities. Over the past year and a half, of course, the other feature of our work has been working in our assessment centers and helping to manage patients locally who have symptoms and sometimes the diagnosis of COVID-19. Most of our colleagues work in rural communities without local access to specialist care. A handful of our communities may have a general surgeon or a general anesthetist, but most of the small communities have no local access to specialist care. And so we rely on either sending our patients to see specialists in person or on telephone and video links to specialist colleagues to support our patients to access the care that they need. And for me and many of my colleagues, our work also involves supporting and shaping the local healthcare system. It means doing some of the administrative work, writing the policies, supporting the development of service delivery pathways within our communities so that we can ensure that for our patients, they are able to receive safe and high quality care in their community context as close to home as possible. And that work, that system level support, is done by the same small handful of physicians who are also managing primary care, emerge departments, and inpatient care all across Northern Ontario. And I think, as has been highlighted, this work has become over the past year and a half increasingly difficult for many. The COVID-19 pandemic has increased the demands on our time because of the breadth of work that's needed to be done, and the press of change for many of our colleagues in order to do the work we've needed to do in the context of the pandemic has been huge, and has also been highlighted. The mental health and addictions issues that were an issue long before the pandemic have accelerated and been very challenging all across the North, including in our small communities. So the work has increased and the demands on our colleagues have increased. And what we're seeing is increasing retirements, departures, and scaling back for our physician colleagues. And that is creating challenges for keeping services open. We have also become increasingly dependent on locum services. And I think, simply to describe that for people, locums are fill-in physicians. They are physicians who come from outside of the community to be able to support in pre-COVID times, to be able to support physicians to take vacation or be able to access education opportunities. But what we're seeing now is an increasing reliance on locum physicians to come in and simply keep the doors of emergency departments open. And the dependence on that has increased year over year for the last couple of years and has never been higher than it is now. Many of our hospitals and many of our colleagues are talking about a fairly imminent risk of emerge department closure if we can't access those locums and if we can't sustain the clinicians who live and work in our communities. It certainly felt harder as well to access mental health and addiction services for our patients. And as has been highlighted, the tragedy of the opioid crisis and the mental health crisis across the North is something that's felt in every community in Northern Ontario, and certainly by all of the citizens and the health providers who live and work here. So to the point of what we need, we know right now that we need almost 100 rural generalist family physicians in our rural communities across the North. We know that we need over 160 specialists to create that clinical health care team that we know our citizens rely on. So more than 160 specialists, and we need an additional more than 40 family physicians in our urban settings to provide care to urban patients and to do some of the work in hospitals that family physicians are very well equipped to do. To sort of summarize that, we need more than 325 physicians currently across the North. And that's a big number. That's almost 20% of the entire workforce that's missing from our physician workforce. And we know that that 325 is actually a significant underestimate because it only includes what we know is needed to meet clinical service demands. It doesn't include the expectations of a maturing medical school and the expectations that our clinicians will in fact teach NOSM learners and learners from other schools. And to do that well takes time. So we know that we're adding that teaching work to the workload of our clinicians who are already very busy. And we need more physicians to be able to do that work well and to ensure that we're training effectively that next generation of clinicians for Northern Ontario. We've been focused, I think, over the last many years, as you've mentioned, Dr. Verma, in terms of NOSM's role on moving the physician workforce from one that is fragile to one that is flourishing. But we've seen over the COVID-19 pandemic time that we've in fact become increasingly fragile. And again, that's due to retirements and departures and burnout. And what I think many of us fear now is that that fragility will become so significant that local health systems actually begin to break down. And we really need to avoid that, because when systems break down, the challenge to rebuild them is immense. And the risk to the people who live in these communities is not small. And I'll say that I know about the challenge of rebuilding firsthand. When we first came to Marathon in 1996, I was a new grad and came here with my family physician partner and 4 of our resident classmates. And at that time, we joined the one physician who was left here in the community. We were told at that time that Marathon had had 85 physicians cycle through the community in the preceding decade. Some came for a couple of months, some came for half a year, many burned out and left. And when we were met by the recruitment committee, they showed us a stack of burlap sacks and said, these are the burlap sacks that we will put over the Blue H hospital signs on the highway, because if we can't recruit, we can't sustain our healthcare service, and our emergency department and likely our hospital will need to close. The threat of closure at that time in 1996 for this community in particular was very real. And I know that the threat of emergency department closure is very real currently. And what I would say is at that time in 1996, the local health system here had begun to break down. The hospital had lost its accreditation. There were policies that hadn't been reviewed and looked at in a decade. And I know that the physicians who came through, those 85 physicians who cycled through, likely provided very good care to every individual patient that they saw. But they didn't have the capacity, they didn't have the bandwidth to do the work that it takes to sustain and support a local system. And so the system here began to break down. And one of the things that the 7 of us who then formed that new clinical group in 1996, one of the things that we did was invest hundreds of hours rebuilding the local system. That challenge was immense. And my hope for our communities across Northern Ontario is that that's not a challenge that any of them will need to face. The recommendations then that the OMA is putting forward now are really important. And given my presence in the North over the past 25 years and my role as Assistant Dean of Physician Workforce Strategy, I am confident that the recommendations that the OMA is bringing forward absolutely reflects what I've heard from colleagues all across the North in the last couple of years. We need to support our physicians and our interprofessional teams to do the work that they can do in the communities across the North to provide access to safe and high quality care as close to home as possible for our citizens. We need to enhance training opportunities for all learners, not just NOSM learners, but all learners who might have an interest in care in Northern Ontario, all learners who can see a future for themselves here, so that they might be able to come back and form part of our physician workforce. We need to take down barriers.
Questions, I think, from reporters. Dr. Verma.
Great.
Yes, thank you, Alan. Thank you, Sarah. You were just being so eloquent. It was hard to, stop you. But listen, let's move to Ashley. We have a number of questions in the chat and a number of reporters waiting to ask questions. Ashley, over to you.
Yes, thank you very much, Dr. Verma. My first question is for Alan Odette. Alan, what will the OMA do to make sure action is taken on these recommendations?
So the OMA launching this platform here in Northern Ontario in Sudbury today. We'll launch tomorrow at Queen's Park. It'll be delivered to all the political leaders, and we are going to spend between now and the election next June to ensure that every one of the political parties and their leaders adopt these recommendations into their platforms.
Thank you, Alan. Follow-up question for you. What will the OMA do a year from now if nothing has changed, or worse yet, even more doctors are leaving the North?
We're going to keep advocating, advocating, advocating. We're going to bring together the strength of all of our physicians, the many community stakeholders that we've worked with, other allied health professionals, and we're going to advocate, advocate, advocate for more integrated, coordinated healthcare for Ontarians, because they deserve it and they want it.
Thank you. My next question is for Dr. Verma. Many Northerners have to travel hours to see specialists. How do you think the backlog of medical care will affect wait times given these additional challenges?
It's absolutely already affecting wait times. There's no doubt that healthcare generally, from even surveillance and screening by general practitioners to surgical wait logs, wait times for the treatment of non-urgent cancer, but cancer that could evolve into urgent cancer. These are all very serious problems. The main solution immediately is to try to expand capacity and to try to build in better incentives for dealing with those work logs, including physician assistants. There's some very emergent things that can be done. The long-term answer, of course, as you know, to address the physician shortages is today that would be 5 graduating classes of the NOSM class. So we don't have that capacity right away, but the long game will have to be able to expand the medical school. But the short game, Ashley, and whoever asked that question, this is a problem right now. And so we need to be able to truncate paths of care and to bring in some additional care from the South to be able to deal with our backlogs.
Thank you very much. My next question is for Dr. Kassam. Dr. Kassam, how can Northern communities attract and retain more physicians?
It's an important question. Dr. Verma was just describing a little bit of how there's an acute need right now. There's 100 generalist family doctors that are needed in this area, 130 specialists, 40 of whom are psychiatrists. And so this is an evergreen issue. It's an issue that affects all of the conversations that we've had so far. And it comes down to a few priorities that we're excited to launch in the coming days. And part of that is reducing wait times in the backlog of services. Close to 20 million points of care have been delayed as a result of COVID-19. This has acutely affected Northern communities and rural communities. We also know expanding mental health and addiction programs in the community is essential. It's our second pillar. It's why we actually went yesterday and visited with Denise Sandel, talking about her son Miles, and so expanding mental health and addictions programs, that's important. That's our second pillar. The third pillar is improving and expanding home and other community care. The fourth pillar is strengthening our public health and pandemic preparedness for the future so that we don't have to continue to experience these deep fractures that have been exacerbated and grown as a result of the pandemic. And finally, and this is what Dr. Verma was talking about, as well as Dr. Newberry, about an integrated healthcare system. We want to be able to make sure that healthcare is integrated across systems, whether south and north, whether that's through digital frameworks that we're establishing. But those are the major 5 pillars, and that's what we're going to focus on.
Thank you, Dr. Kassam. Follow-up question for you. Why are you launching your platform in Northern Ontario first?
So the North matters. And, you know, when we look at the statistics that are staggering, the northern and rural communities are, as far as disparities are concerned, as far as mental health and addiction services, other types of healthcare services, and the suffering that happens in these regions compared to others is a profound one. And we learned about that this morning with a bunch of healthcare leaders who are expounding upon their experiences here with under-resourcing, which has happened for close to 30 years now. And so this is an important area to pay attention to. We need to highlight the disparities that exist and ultimately create a roadmap for the future. And that's exactly what the OMA has with our prescription for Ontario.
Thank you, Dr. Kassam. Next question also for you. Can the OMA make it mandatory for doctors to work in the North?
So I think when we think about health human resourcing across the province, especially in northern and rural communities, we have to align incentives. And that's what we have to figure out a path forward with. And Dr. Verma has talked about this at length in her capacity as dean at NASM, and talking about expansion of cohorts, but also trying to not only train, but also retain physicians. And how do we do that? How do we get people who understand the communities, who have a deep connection to these areas? How do we get folks to not only be educated here, but ultimately stay and serve? And I think that is that's part of aligning incentives. It's providing resources for education, providing resources for the health human resource infrastructure, but also healthcare infrastructure. The OMA is excited to continue to advocate for that, and we're going to continue to make sure that this becomes a priority, not only for us here at the OMA, but for all political parties over the course of the next months and years.
Thank you, Dr. Kassam. This next question is for Alan Odette. Alan, has the OMA ever had a president from Northern Ontario? How can we make that happen?
I'm not sure whether we've had a president from Northern Ontario. Dr. Newberry is saying yes. I know we've had many board directors. Dr. Kozar from just here in Sudbury, and a host of others.
I think we've had two, Alan, Dr. Janice Willett.
Oh, right.
Great. And I think Dr. Stuart Kennedy from Thunder
Yeah,
Bay.
Dr. Kennedy. So there, the short answer is yes, we have. And how do we get more? Well, you know what? Dr. Kassam are here in Northern Ontario today, trying to engage with members.
Thank you very much. This next question is for Dr. Newberry. What is the most urgent action needed? What can the OMA do now to most help us here in the North?
Yeah, thanks for that question. So really the most urgent thing that we need to do, Adam has already spoken to, which is aligning incentives to stabilize the workforce that we have currently. We can't actually afford to lose any physician from the North right now. So providing them with the supports that they need, both clinical incentives and also supports to do the work that they need to do, the mental health and addiction supports. We need to respond to the needs of clinicians now so that they'll stay, so that they can be a stable workforce to teach the next wave. And the OMA is already participating and advocating in that quite strongly for us.
Thank you very much. This next question is for Dr. Kassam. Will this Northern platform make an impact on Northern healthcare? How is your plan different than previous plans?
Well, we absolutely hope so. That's the whole point of doing a campaign in a platform like this. We want to be able to effect change. We know that healthcare stakeholders like government, like healthcare institutions, like NASM, like the OMA have a role to play. And our job is to convene those groups in order to, again, build a roadmap for the future. We believe that we're in a significant moment of change. We've been impacted quite substantially by the pandemic. And we know that fundamentally healthcare has shifted. And so we need to be part of that change. And we believe very strongly that doctors are at the core of that change, and not only have the experience and expertise, but ultimately the vision for how we can move into the future in order to make sure that patients can continue to get care at the time that they need it.
Thank you, Dr. Kassam. This next question is for yourself and Alan. What is the most important recommendation in your platform?
We have 5 major recommendations. The first is figuring out 5 major pillars, of which we have 86 recommendations that follow thereafter. Those 5 areas, the first is the pandemic backlog of care. 20 million points of care have been delayed as a result of COVID-19. That's someone's hip or knee replacement that's gone delayed. It's someone's cataract surgery that's gone delayed. It's someone's mammogram or colonoscopy or cancer screening or diagnostic care that's gone delayed. Pandemic backlog of care is our first pillar. Our second pillar is access to mental health and addiction services. We talked about this here in the North with a number of different stakeholders. That is something that is a chief concern for our organization, but also for frontline healthcare workers. Our third pillar is making sure that we are creating a robust system for home, community, and long-term care. I'll be up here on Thursday treating patients at the Falcon Bridge Center, and this is going to be a continued commitment, not only by myself, but of course of our organization. How do we support long-term care, home care, community care? Number 4 is pandemic proofing the future. We should have been ready for this pandemic. We got to be ready for the next. We need all levels of government to step up to the plate. And number 5 is creating creating an integrated framework for care delivery across sectors within the healthcare sphere, and that's what we're going to continue to advocate for as well. So those are our 5 major pillars.
I would only add, Ashley, building on Dr. Kassam's previous answer, this is the first time in 140 years that the OMA has ever taken on a task like this. And we're doing it because it's not all about doctors. It's about community. And we've reached, frankly, a crossroads where if we don't work across political parties, if we don't work across health and allied health spectrums, we're never going to be successful at managing some of these very critical and in some case crisis issues in our communities, and in this case northern and rural communities. So we've consulted with literally thousands and thousands of healthcare professionals and others on this, and that's how we landed on the 5 key areas of priority. And we're trying to project map this in a way that addresses the most current and urgent, with some of the more near and midterm, and underlying all that with some strategic planning and build a critical path to the future. Dr. Verma described earlier getting in front of that cohort, that shortage of physicians. You don't just turn that switch on and off. To meet the current needs would take roughly 4 or 5 cycles of NOSM's medical school. So we're here to play part of a role in enabling a more collective group of people to say, you know what, healthcare matters to all Ontarians. It matters today in our discussions in Northern Ontario, but it matters to everybody, and everyone needs to get rowing in the right direction.
Thank you very much. Another question for Dr. Kassam. How do you plan on getting more doctors to go to the north? Has having a medical school up there helped at all?
Well, I'll let Dr. Verma maybe comment on this a little bit, but she, in her opening remarks, talked a little bit about how NOSM has created, I think, 800 or 700 practicing physicians. That's a lot of physicians. And so I believe that NOSM in Northern education has a role to play. We also have to think about, not only attracting but retaining folks to stay. Dr. Newberry in her comment was talking, or in her remarks was talking about locum physicians coming up to the north. And so I think that this is a very complex problem. There's probably a bunch of different avenues that we need to figure out how to work in concert, but ultimately it's going to be a multi-pronged approach that includes homegrown training, attracting from abroad, and abroad from the community, as well as focusing on how do we fundamentally allow people to get care here with the health human resource plan that we have in place.
And I'm going to answer the question, Ashley, that of course, we've made a huge difference as a key government strategy that's been highly successful. In 13 short years, we've produced close to 800 doctors and 700 residents. And if they stay to do both their MD and their residency, 89% of them stay in Northern Ontario. But to get into NOSM, it's a 3% success rate, 2,400 applications for 64 spots, 5 cycles, as Mr. Odette said, to meet the current needs today. And we need to train people here. We need to have access to rural training opportunities. That is one of the recommendations, actually, that's in the list. But we can't do that if 50% of our doctors are poising to retire because of burnout or aging. So we need enhanced locum programs for sure. I completely agree with Dr. Kassam, but we also need expansion of the medical school and support for clinical teachers who do not have any protected academic time. So in that vein, health starts here. Health will be successful here if we can make those systemic changes that I believe will actually make the impossible possible in Northern Ontario.
Thank you very much, Dr. Verma. I'd like to take the opportunity now to ask media who are on this call if they have any additional questions for our panelists. I have one from Len Gillis. One of the realities of Northern Ontario healthcare is the fact that many Northerners still need to travel to the south to get specialist care. Does the OMA or NOSM support any immediate improvements to travel infrastructure, such as trains, buses, or orange flights to help Northerners get quick and accessible healthcare?
I can take that one, Ashley, if you'd like. So certainly, given the vastness of the region, there's not only transport infrastructure challenges, but also technology infrastructure challenges. So access to broadband, the internet, we've seen a rise in the ability of physicians to deliver care virtually. Obviously, that's a pendulum that is swinging in real time, but nevertheless, if you don't have access to broadband internet, you're going to have access problems. And so this question was specifically about travel. And to Dr. Verma and Dr. Newberry's point, in an ideal world, we have more specialists and infrastructure here, so people aren't traveling. And so how do we get to a point where we can actually provide service in the places where folks live and work and have communities and live? And so that is sort of the challenge. The challenge is, how do we develop local infrastructure? We need supports from government. We need supports from other healthcare stakeholders. And that, I think, is the path for success.
And travel's not the answer, Ashley. It is one of the answers for high-end urgent care. But if you're a parent and your child has to go to sick kids for specialized care, and not both parents can be there, nor can they afford to stay in a hotel. If you're a mother giving birth and your support system can't be there, these are very challenging situations, social and emotional situations that do not offer the right answers. As Dr. Kassam said, homegrown, having the access to care here, unless it's so highly specialized. We have two fantastic health sciences networks here, HSN and the Thunder Bay Regional Health Sciences Hospital. They are capable of fantastic care.
And if I could maybe just add, I think the work that Dr. Kassam exemplifies, specialists who come to the north, when we've certainly seen a huge limit on that through the pandemic, when travel across public health units was so limited, and patients have felt the absence of specialists like Dr. Kassam, who just weren't able to travel during the pandemic. But the more that we can bring specialists to communities, the greater the sense of satisfaction and the greater the ease for patients to be able to access the care that they need.
And by the way, this is really for you, Ellen, but the government currently spends almost $70 million on the Northern Health Travel Grant to bring patients to physicians down south. If a portion, just even a quarter of that, was reinvested into increased MD training and residency training, we can actually grow our own on the north, as Dr. Kassam recommended.
Thank you very much. That concludes our Q&A session for today. Thanks everyone for your questions. I'm now going to turn it back over to Dr. Verma for closing remarks.
Merci beaucoup, Miigwech. Thank you very much. Very, very grateful to the Ontario Medical Association, to Ontario's doctors, to Dr. Adam Kassam, Mr. Alan Odette, and of course the entire team, Ashley Molnar, for such great Q&A, stick handling. I really feel that we have had an unprecedented moment here of having you here at NOSM in Sudbury. We've made a meteoric journey in just short 13 classes and 17 years to go from being an idea in a cabinet minute to now becoming Canada's first freestanding medical university. And people will say, well, why does that matter? I know my colleagues on the line from media, Lynn and Alex and Martha and Ian and others will say, well, why does it matter? Well, it matters up here because higher education with community, with education and health, and the impact on health has an impact on the wealth of the community, and we aim to make a difference. This partnership today is an example of the kinds of communications and conversations that we can bring together for Northern Ontario. Merci beaucoup, Miigwech. Thank you very much to all of you today for attending, and we're happy to hear from you if you have any further questions, of course, through the OMA press office.